Good afternoon, everyone, and welcome to the Jamie Barkin Endowed Lecture for Medical Grand Rounds. I'm Jody Barkin. I happen to be intrinsically related to Jamie Barkin, but he is now a professor emeritus and trained approximately 225 gastroenterologists during his career as faculty here, along with countless residents, fellows, medical students, and observers over time. And his lasting impact to the field is really in what we see in our trainees with education and mentorship. And that's why this lecture was established in his honor as part of his legacy. We're graciously supported in part by the generosity of Linda Corey in honor of the memory of her father, Kenneth Hoy, with whom this lecture is possible. And while the official introduction will come from Dr. McBride, today we're really lucky to have Seth Gross with us. He's an incredible person, a true physician leader and physician advocate for our field and our patients, and an amazing colleague and mentor. And with that, Dr. McBride.
Thank you, Dr. Barkin. Hello, everyone. My name is Andrew McBride. I'm one of the chief medical residents, and I'm honored to introduce today's speaker for the Department of Medicine Grand Rounds. Dr. Seth Gross is a professor of medicine at the New York University Grossman School of Medicine and is clinical chief of the Division of Gastroenterology and Hepatology at NYU Langone Health. Dr. Gross graduated medical school from the Tel Aviv University and completed his internal medicine training at the Zucker School of Medicine at Hofstra University. He then was a fellow at the Mayo Clinic in gastroenterology. As a gastroenterologist, Dr. Gross specializes in advanced endoscopic procedures. His clinical practice is focused on the prevention, diagnosis, and treatment of gastrointestinal precancerous conditions and cancers, such as esophageal cancer, colorectal cancer, and pancreatic cancer. Dr. Gross's research interests lie in gastrointestinal malignancies, as well as quality and innovation in endoscopy, most recently in the area of artificial intelligence. He has published over 140 manuscripts and 150 abstract presentations. Dr. Gross oversees the clinical programming and quality initiatives for the Division of Gastroenterology and Hepatology at NYU. He is a member of the U.S. Multi-Society Task Force on Colorectal Cancer and a trustee on the board of the American College of Gastroenterology. He is a former associate editor for the Journal of Gastrointestinal Endoscopy, and currently he hosts an internal medicine radio show on Dr. Radio for SiriusXM. Please join me in welcoming Dr. Gross to the Department of Medicine Grand Rounds.
Good afternoon, everybody. Thanks very much for that really kind introduction. 20 years ago, I did a 1-month rotation and I worked with the senior Dr. Barkin. So it's a true honor to come back here and give this lecture. When I first started out in academic medicine, I remember one of my youngest kids, he was in kindergarten, and I always tell this story because it makes me laugh. My wife is also a physician, and they went around the classroom and they asked, what do your parents do? And so he quickly said, my mom's a doctor and deals with bones, and my dad goes on vacation all the time. And it's today exciting for me to have one of my kids here who's actually finishing her freshman year at the University of Miami to actually see that I don't just go on vacation. I get to do these educational programs and build on the field of gastroenterology. Today, we're going to talk about an area that's really important, especially for those that are working in the hospital, which is gastrointestinal bleeding. And we're going to go over not just upper gastrointestinal bleeding, but we're going to cover the small bowel and lower GI bleeding. Because we don't always know, even though the clinical presentations could be very clear of what we think it is. Is it an ulcer? Is it an AVM from the small bowel? Or is it a diverticular bleed? Thankfully, most of the time, it's consistent with what we've learned, but other times it's unexpected. And when we think about the origins of GI bleeding, you always have to remember common things are common. So 80% of bleeding is in the upper GI tract, 15% in the lower GI tract. And probably the most frustrating and challenging is mid-GI bleeding, about 5%, but consumes so much of our time, which is small bowel bleeding. So first we'll touch on upper GI bleeding. It's one of the most common GI diagnoses for hospital admission. 80% of patients do require admission, and the signs could be everything from vomiting blood, coffee ground emesis, melena, hematochezia if it's a significant bleed. And when we think of the sources of bleeding, we always have to be open-minded that someone that has coffee ground emesis or melena, for instance, not only could have an upper GI bleed, especially for melena, but they could have a right-sided colon bleed. It doesn't mean that you shouldn't start to consider upper endoscopy, but if that upper endoscopy is negative, then you have to go to the next most likely place. Same thing with bright red blood per rectum. Our first thought is that it's coming from the lower GI tract, it's coming from the colon. But if someone is very sick and hemodynamically unstable, you have to take pause and think, well, maybe this is a significant upper gastrointestinal bleed and it's from a significant ulcer. These are the most common etiologies. From the esophagus, we see varices, probably the main thing we would see in a hospital. Stomach, peptic ulcer disease, same for the duodenum, even though we will come across malignancy and portal hypertensive gastropathy or even GAVE. And then there's the obscure, which is hemophilia and aortic enteric fistula. So that's why history is very important. And sometimes it's iatrogenic. Someone's had a procedure and they come back to the hospital. So really knowing the history and what's happened with someone is critically important to trying to figure out the etiology. There are risk stratification scores that are always mentioned in the literature because it's an objective way to figure out what's going on with someone. But I read many of our training notes where I am in New York, and I really don't see the GBS score mentioned in the assessment and plan. But when you look at the literature, this is what they use. And it's important to know that if someone has a very low score, the likelihood of them needing hospital admission is very low, and they could safely get discharged and follow up as an outpatient. But I think we're coming into a very exciting time in medicine when we think about artificial intelligence. The artificial intelligence that I deal with today is in the procedure space, and I spoke with the GI fellows this morning about AI and colonoscopy, but we are starting to see the use of big data to better risk stratify patients. And if you think about upper GI bleeding, imagine being able to have someone present to the emergency room. The AI algorithm is able to look at all the data that has been put into their medical record and give a recommendation of should this patient come home or should this patient get admitted to the hospital, really outperforming the bleeding scores that exist. And I think we're going to see more and more of this in
going to the chief person.
I guess that's someone on Zoom. I thought it was a slide. Sometimes you record your slides. I thought I deleted that. One of the most important things is the pre-endoscopy assessment and getting the patient ready for the procedure. And that's why I think there's such synergy between the internists and the gastroenterologists for really optimizing these patients to make sure that we could identify their source of bleeding and treat them timely. So we do our risk stratification. There's always talk about, should you give erythromycin or some prokinetic? I think there's certainly value to that. The key thing is for the person putting the orders in, I know at least where I am, the GI fellows or the GI team do not put in the orders. It's the medical team. You can't treat, giving a prokinetic or an antibiotic. You can't put it over 2 hours, right? This has to rapidly get into the patient so the timing is right for when they do come down to endoscopy, and then that stomach will be nice and empty. Another big thing that's changed when we look at GI bleeding guidelines for upper GI bleeding is the transfusion threshold. We used to over-transfuse patients when they would come in. And now we have this restrictive strategy, which shows just as good an outcome, where you really want to not think about transfusion for an average risk person if their hemoglobin is above 7. Now, it's different if they have some cardiac disease, you're worried about acute coronary syndrome, where you're going to want to start transfusing those patients to be above 8. There's all this talk about proton pump inhibitors, and the most recent guidelines that were put out by one of the GI societies is that they're not for or against it. They couldn't really meet consensus. My personal experience is we don't need to necessarily rush someone to endoscopy because sometimes it's too soon. And I find having an IV PPI on board for several hours actually makes that exam a bit easier. Things clear up in the stomach, you're able to see things better, and if there's therapeutic intervention, you're able to do that. The Forest classification is how we grade peptic ulcer disease. And it risk stratifies based on what type of ulcer you see, since not all ulcers are equal. And I do encourage those of you that reach out to the GI service to look at the endoscopy report, but not the text, but look at the pictures, so you get an understanding of what we're seeing. And it really just depends on if there's actively bleeding or spurting, which is a class 1A. We don't see that much, but those are the sickest patients. The most common thing we often see is a clean-based ulcer, which means that there's no signs of a blood vessel creeping up, and we usually don't need to even do endoscopic intervention, and those patients could soon go home. But depending on the type of finding of the ulcer will determine the risk of rebleeding. So if you have active bleeding or a non-bleeding visible vessel, this is where you'll see the endoscopist treat the patient and do endoscopic therapy, which we'll talk about in a few moments, to try to reduce the risk of rebleeding in conjunction of putting them on a proton pump inhibitor afterwards. So when we think about when we should do endoscopy, we used to try to get these patients down as fast as possible to get them to the endoscopy unit. But the literature has taught us that within 24 hours of presentation is a very reasonable time to get an upper endoscopy. And that's really critical to just make sure that we don't want to delay them too much. But I suspect that if you look at your average time from when patients enters the hospital to when they get their endoscopy, I think most places are probably around 12, as long as they have the resources in place. What are the different types of endoscopic treatment that you may read about? Usually it's in combination. So we tend to do injection of epinephrine and either putting on a metal clip or some heat therapy. We should never do epinephrine alone. Sometimes we'll inject, alcohol if it's a gastric varix. And then there are some newer innovations in the world of GI bleeding, which is important for you to be aware about. There are certain clips that are much larger than a traditional hemoclip that could get a really big bite of an ulcer to control bleeding. There's a powder that we could sometimes use to get immediate hemostasis in someone, where when it first came out, it was viewed as more of a rescue therapy. But in recent literature, it's just as good as standard therapy. So depending on the endoscopic features, whether it's a visible vessel, we're going to do endoscopic therapy and a proton pump inhibitor. But then if you have a flat pigmented spot, where you think it might be a blood vessel, there's really no endoscopic therapy needed. That adherent clot is always a bit tricky because we don't always know what lies underneath. And it's really important when the patient has that procedure that the endoscopist clears that clot to see what's underneath. And then, of course, we talked about clean-based ulcers where the risk of bleeding is quite low, and we could just put them on an oral proton pump inhibitor. So post-endoscopy, we put them on a high proton pump inhibitor for an actively bleeding ulcer to reduce the bleeding and future mortality. And then we would keep them on that for 2 weeks or so. Many people will keep them on that longer. And then we would do a subsequent endoscopy, probably about 8 weeks afterwards. And the main reason to do that is sometimes the gastric ulcer is the initial presentation for malignancy, and we have to make sure that the person doesn't have an underlying gastric malignancy that presented as an ulcer. So when we think about risk stratifying patients, very low versus not very low clinical risk, it essentially is who could go home, who needs to be admitted, and once they do get admitted, we're going to do pre-endoscopic management, which is critically important, which is adequate resuscitation, not over-transfusing them, giving a prokinetic when appropriate, and then timely endoscopy. And then based on those findings, we'll determine who needs to stay for a couple of days with high-dose PPI and who could go home. Probably one of the biggest things that we struggle with is rebleeding. Rebleeding happens, even when the best intention in terms of endoscopic therapy was performed. Fortunately, though, repeat endoscopy success is as high as 75%, and I think it's probably higher today with some of these new modalities, the bigger clips, the hemostatic agents, where you don't really need to bring someone to interventional radiology. And I can't remember the last time someone went for surgery for gastrointestinal bleeding. But usually if we're not successful in endoscopy, interventional radiology will do the job. So what are some novel technologies that you may not be aware of for gastrointestinal bleeding? So first is this over-the-scope clip. This over-the-scope clip gives a much larger bite of an ulcer than those conventional clips that just have two jaws. So you can see that there are jaws essentially all the way around, and it's fit on the outside of the scope. And this was originally for perforation. That's where it started. So if someone had a iatrogenic perforation from a polypectomy or from a scope itself, or if patients develop fistulas, say from bariatric surgery, these over-the-scope clips would be able to close those areas and you could avoid surgery. And then endoscopists and gastroenterologists started to apply this for rebleeding with peptic ulcer disease. So there was a famous trial called the STING study. And what they did is they randomized patients to the over-the-scope clip versus standard therapy. And you could see that the rebleeding rate was significantly less with the over-the-scope clip. And I think this is important because this type of clip has really lived in the world of interventional endoscopy, the advanced endoscopists you call for things like ERCP. But I think this is a skill that any gastroenterologist should be able to be comfortable to do and learn, because it could really make a big difference when you're managing something like peptic ulcer disease. So there was a study in the United States, a single center study looking at 53 patients. And again, when you look at the rebleeding, it was 29% with the over-the-scope clip, with actually standard therapy, and 4% with the over-the-scope clip. So there's a significant risk reduction if you find yourself that this is the best intervention to do. Now, again, this used to be a rescue therapy, but speaking with our GI hospitalist, they're using this as first line when appropriate. When you have a very large ulcer base and they don't feel they could do heat therapy and epinephrine or just put conventional hemoclips on, they are going right to the over-the-scope clip. And I'm going to show you some videos about that. And you see again here that there is benefit with an over-the-scope clip in the right patient. So I'm definitely not saying that every time someone comes in for an upper gastrointestinal bleed and they have peptic ulcer, a large ulcer, they should get an over-the-scope clip, but it's something that we have to think about in the armamentarium when we're risk stratifying these patients. And this was another study, STING 2, which was the follow-up to STING 1, again showing improvement in the decrease in the rebleeding rate after therapy. Another thing that we've started to use is the endoscopic Doppler probe. Now, this has been around for several years, and it's exactly what you think. The whole idea is that we could see an ulcer base, and in this cartoon, there's that red area where you think that's your best target, and we'll tend to treat that. But what if you use the Doppler probe and to the right or to the left or just above it? That's really the biggest risk for bleeding, because that's where the blood vessel flow is. And so how do you use this? It's very similar to what we do with other endoscopic tools. It's just a blunt probe that you put up against the area. And you can see there's that red nipple there where you would say that's a visible vessel. But again, you have to really probe the whole ulcer if you're using that Doppler probe. And the whole purpose of this is to get the right therapy during the first endoscopy to prevent rebleeding. And there is a few trials out there looking at the rate of rebleeding with the standard approach, which is looking and inspecting and then doing endoscopic therapy, versus using a Doppler probe and then doing endoscopic therapy. And you could see that for an active arterial bleed, for instance, with standard, the rebleed rate was 50% versus 28.6% with the Doppler probe. So you definitely got some improvement of more targeted therapy. Even though ulcers are usually not that big, you want to be able to put the therapy in the right area. This was another meta-analysis, again, showing the benefits of a Doppler probe compared to standard therapy. And this is something that our inpatient service is using on a regular basis. Sometimes during the index endoscopy, when things are not obvious, but especially for the rebleed, they are really using this Doppler probe. So here's a question for you. This is a 71-year-old man on anticoagulation, presents with syncope, has a 2-gram hemoglobin drop, and endoscopy is performed within 12 hours. And you have 4 different areas to figure out, where am I going to treat? So you have 1, 2, and 3. Those look pretty bland to me on the endoscopy. You have 4, which maybe has a pigmented spot, and that ulcer looks so much bigger. And you're going to say to yourself, if I have to treat one area, I'm going to treat that area. But the reality is, when they used the Doppler probe, it was number 3. That was the ulcer that had the highest Doppler flow, and that was the one that endoscopic therapy was performed. So when you're in a situation when you're not sure, it could certainly give us more clarity. Let's see. We'll give you some cases. So this is an 82-year-old woman with rheumatoid arthritis on NSAIDs, presents with hematemesis. And so we're in the stomach. You always want to do a lot of irrigation. They're irrigating this ulcer base, and then we're going to start to see some oozing. You know, nothing overwhelming, you know, certainly very manageable. You know, this is what it looked like on still images. This is what it looked like when they cleared the blood from it. And on day 3, she had recurrent acute anemia. They looked at the ulcer bed again. They were not impressed, and they decided that they weren't going to do intervention. Now, keep in mind, it wasn't the same endoscopist managing this patient, because it was the day endoscopist and the night endoscopist, and then it comes back to the day endoscopist. So on day 7, another bout of acute anemia, and this patient was in the hospital for other reasons, but she dropped her hemoglobin again. So they decided to use the Doppler probe, because this was one of our physicians that has a lot of experience with this. And you could see that the probe is out, and you could hear the Doppler flow. And it's sort of navigating her away from where the stigmata is located to say, you know what, we need to cover a bigger area. Hemostatic clips with a single 2 jaws is not going to be enough. And she deploys one of these over the scope clips. And you could see that it looks intimidating, but it completely treated and prevented future rebleeding. So this is another patient, 50-year-old man, chronic back pain, presented to an outside hospital with syncope, had a duodenal ulcer, left against medical advice, of course, came to our hospital. And again, similar situation. This time there is a clip from the prior endoscopy, and we're using the Doppler probe to get a better sense of, we have a clip there. Why is the patient rebleeding? And again, it's just that more precise targeted therapy that could really make a big difference for this patient. And this particular endoscopist is a very big fan of the over-the-scope clip. So you saw one, they're all sort of similar, and they put another over-the-scope clip. This is an 83-year-old man admitted with pneumonia, became hemodynamically unstable with melena and hypotension, was on a blood thinner for a deep vein thrombosis. And you could see here, there's a big blood clot up in the fundus. You see the scope looking back at itself. They're trying to probe this clot, and they saw that this was a really big area, not amenable to traditional therapy, which is electrocautery and epinephrine, or epinephrine with a clip, and they put an over-the-scope clip on. And this is being done by a general gastroenterologist that's covering the service that has experience. If you think back a couple of years ago, we'd be calling the advanced service to try to help us with something like this. And this again goes to show there are things that happen in interventional endoscopy that should be learned by those that are doing general gastroenterology. This is another example. Again, large ulcer base with bleeding, and you could see the evidence of that over the scope clip. And then that over the scope clip will ultimately get deployed and immediately cause hemostasis, but also prevented no further rebleeding. Now, these over the scope clips, unlike traditional single 2-jaw hemo clips, they don't necessarily fall off like the other clips do. So the company actually has a device that if you need to, you could go in and disengage the jaws of this clip to safely remove it. And we'll see that being deployed in a moment. And you can see that the clip is deployed and there's hemostasis. Another big invention that reached us here in the US that was in Europe for years is this idea of hemostatic powder. What's nice about hemostatic powder compared to traditional endoscopic therapy is traditional endoscopic therapy has to be very precise. You really have to know your target, whether you're doing heat therapy or putting a clip on, whereas hemostatic powder is really like spray painting. So if you're in a difficult situation, you don't necessarily have to be so precise, but you could cover a really large area to get immediate hemostasis. The key for most of the hemostatic agents is you need active bleeding. So you'll never read an endoscopy report that says there was a clean base ulcer and the doctor decided to place some hemostatic agent just to give some extra insurance because it just doesn't work that way. You definitely need to have active bleeding. Originally, this was used as a rescue therapy, but there's been some literature from overseas to suggest that there's benefits as a primary therapy for peptic ulcer disease. And it's also been used for tumor bleeding. Probably one of the biggest challenges we face in GI sometimes is patients with recurrent tumor bleeding from esophagus cancer, from stomach cancer, and we try other modalities that just get the bleeding going even more. So this was a non-inferiority randomized controlled trial looking at the role of hemostatic powder. And you can see that the hemostatic powder rebleed rate was 10.2%. Standard therapy was 18.9%. To give us that reassurance that if we just could only use this, because oftentimes significant gastrointestinal bleeding, those endoscopies are happening in the middle of the night in many places, not when we have a full staff during the day, or you're in a remote area and you don't have the skill set to deal with a significant gastrointestinal bleed. This could give you immediate hemostasis and stabilize that patient. So this is a patient with von Willebrand's deficiency, grade D esophagitis, discontinued the PPI, presents with vomiting blood. And when you go down to do this endoscopy, it's somewhat intimidating. There's a lot of blood, there's active bleeding. And could we temporize this and get hemostasis without one having to send them to interventional radiology? Because this is not something that you're going to be able to easily manage when it's this diffuse with traditional modalities. And you see this snowstorm effect. And what it's doing is it creates a barrier layer when there's active bleeding and you get immediate hemostasis. And we don't necessarily bring these patients back for second look endoscopy. We just monitor them clinically, maximize their acid reducing medication, and then they should be okay to go home. So now we're going to transition to, if you talk to some gastroenterologists, it's their least favorite type of bleeding. I do a lot of deep enteroscopy, so I wouldn't say it's my favorite, but I don't mind it. And that's small bowel bleeding, the most frustrating 5% of all bleeding. It's frustrating for physicians and it's frustrating for patients because we could do a workup on them and they could have a capsule endoscopy, and I'll show you some videos of that. And then we do the enteroscopy to look in the small bowel and we tell them we didn't find anything, or we treated one of the AVMs, but there could be others, and they have a hard time understanding that they're not done and they may see us again. And that's probably one of the biggest frustrations with small bowel bleeding. So we have overt small bowel bleeding and occult. Overt is when you see it, where they're having symptoms of melena or hematochezia. And then there's occult where it's more subtle. These patients are more managed in the outpatient setting. They just have this chronic anemia, intermittent episodes of maybe changing their bowel habits. And they're managing with outside IV iron infusions. They never really need a blood transfusion. Most common causes are broken down by age. Under 40, you think of IBD, Meckel's diverticulum, polyposis syndrome. Over 40, angiodysplasia is probably the main one. Doulofoy lesions in both groups are very tricky to identify because they have to be active bleeding. Otherwise, you're never going to find them. You need to find a segment of the bowel or in the stomach, wherever these could develop, and they need to be actively bleeding because it's a submucosal vessel. And when the bleeding stops, that surface looks completely normal. And then, of course, we have some really extreme things that you read about in textbooks that could cause small bowel bleeding. But there's some good algorithms of how we manage this. If it's overt, repeat endoscopy. Even when you think it's small bowel bleeding, so many things are found within the reach of an endoscope or a colonoscope. So it's really important to consider repeating the exam, especially if the endoscopist that's now evaluating the patient did not do the first one. If they don't find anything, then you proceed with small bowel evaluation. Most of the time, we're heading towards video capsule endoscopy, where we take a video of the small intestine. If we're suspicious for stricture or maybe IBD or malignancy, they may get a CT enterography. And then depending on if it's positive or negative, if the video capsule is positive, we may send them most likely for deep enteroscopy because that's more readily available. Less likely surgery, and I haven't really done many intraoperative enteroscopies. If it's negative on the video capsule, you may send them for radiology imaging. If that's negative, sometimes you're sort of just stuck and you don't have a definitive source, even though they're showing clinical signs of bleeding. You just support them, observe them, and give them, oral iron supplement, or sometimes IV iron. Now, there have been some changes in video capsule endoscopy that I think it's important to highlight. So what's new? I was talking to some of the faculty here at Miami, and doing an inpatient capsule is not so new for them, which is good, but many places will not offer that. And then there's a recent advance of artificial intelligence to read the capsule images. So we did a study a couple of years ago to see what would happen with our patients if they were getting an inpatient capsule. So these are patients that had a negative upper endoscopy and colonoscopy, and oftentimes in most hospitals, these patients will be discharged once they're hemodynamically stable. We're able to offer a capsule endoscopy, and we have deep enteroscopy services. We had 131 patients, 100 exams were complete, 77% had a capsule endoscopy, 73% had findings, and it's that 35.1% that had active bleeding. So if we could find active bleeding and within 24 hours or so get them to enteroscopy, there's a very good chance that the rate of rebleed and them coming back is extremely low, and that's really important. So this is something that we've been doing for a few years now, and it seems to work in our patient population. Our GI hospitalist happens to be trained in deep enteroscopy, so we always have someone on site to quickly do these cases. Now, capsule endoscopy has been around for a really long time, over 20 years. I remember when it first came out, I was just entering my residency. It's really transformed how we look at the small bowel. They weren't sure back then if small bowel series would be as good as capsule endoscopy. But you have to look at, 50 to 60,000 frames, and you have to make sure that you don't miss anything. And this is just an example of active bleeding seen on capsule endoscopy. And on the other side, you're going to see at 9 o'clock a small AVM. And a small AVM is something that could cause that degree of bleeding. And when we see that, you saw it just pass. Now, the nice part about capsule endoscopy is we have the ability to back up, look at those frames, and really see. Now, the challenge with the small bowel is it's 18 to 20 feet in length. There's no good landmarks when you're down there. So you really never know that you're close. You hope you're close. You base it off of the percentage of time where it is in the small bowel, and that I would say that 60% mark, if it's 60% or less, you would start with a oral approach into the small bowel. And if it gets beyond 60%, then you have to consider a colon approach. But even then, there's really no guarantee for these AVMs. And then the other thing that happens is when these patients are sedated for the procedure, their physiology changes from the sedation. And these AVMs sort of start to blend back into the background. And I've seen AVMs right in front of me. I turn my head to get the probe to burn them, and then it just disappears. So that's another challenge. You have to really be quick to capture them. Now, what if we introduced artificial intelligence into capsule endoscopy? This is something that we have in colonoscopy, and recently is FDA approved for capsule endoscopy, where you're doing a capsule exam and you get these bounding boxes to highlight the abnormalities. But it does something one step before that. It looks at the 50,000 frames and only highlights the abnormal ones. And there's really nice, good sensitivity and specificity. So they train on a lot of images, over 150,000, and they saw a sensitivity of 99% and a 99% lesion analysis accuracy. But what it has really done, we could get to the next slide, it has decreased the read time. The average read time for capsule endoscopy is probably about 30 to 40 minutes, depending on who you talk to. But it could take that interpretation downtime down to 5 minutes. And that's a significant improvement to what we're currently doing. And if it has something that with very high sensitivity and specificity, it gives us that reassurance that we're going to accurately evaluate the small bowel. And if there's a finding, we're going to be able to identify it. Now, I can't stress the importance of second look endoscopy or colonoscopy. So this was a patient that I had seen a bunch of years ago, and probably the gastroenterologist in the room may have never seen an image like this. I did a double balloon enteroscopy, oral approach, got all the way to what I thought was the transverse colon, and I only started to see blood in the colon. We piggybacked with a colonoscope to just take a picture of the double balloon scope looking at us. And again, I can't stress that before you commit people to a small bowel evaluation, you should consider looking at, was the endoscopy high quality? Was the colonoscopy high quality? You know, could the source, which a very good chance, be in reachable areas before you commit them to a small bowel evaluation? Just to give you a sense of how double balloon enteroscopy works, many people don't understand the principles of it. You know, think of your intestine as an accordion or a slinky. Let's see if it's going to behave. Well, if it were to work, the scope would come all the way down here to the to the jejunum, and there's a balloon at the tip, and the balloon inflates. So that's your anchoring balloon. The scope has an overtube on top of it, and then the overtube goes right up to that first balloon, and so you have two balloons inflated. And when you pull back on the intestine with the two balloons inflated, you're anchored, and all the intestine that's behind those balloons, instead of being stretched out, it gets pleated, like you're closing an accordion or tightening up a slinky, and that allows us to deeply penetrate into the small bowel. And you could actually get all the way to the colon, but you don't need to. You just need to get to your target. That's the most important thing. And these are common enteroscopy findings: AVM, Meckel's diverticulum, Putziger polyposis, multifocal carcinoid. When we have a lesion target, those are so much easier to go after versus AVMs. AVMs I find to be very, very challenging. When we think about managing bleeding for brisk or massive small bowel bleeding, if you have an unstable patient, you have to stabilize them. These are the patients that are coming in sometimes in the middle of the night. They may not be ready to do an endoscopy, and you're going to send them to interventional radiology. You just have to hope that they're bleeding at the right rate for the radiology imaging to capture. Because sometimes you could have someone that's been bleeding at a heavy rate because you see they're hemodynamically unstable, their hemoglobin is down, and it takes some time for them to get to IR or just to radiology in general. And by the time they get there, with the resuscitation, the bleeding has subsided and it has slowed down, even though they may be passing melena or bright red blood per rectum. Subacute bleeding is something that we see more in the outpatient setting. Again, these are these patients that have chronic anemia. Most of the time, they're not in the hospital. They're being managed on the outside. I will see them for deep enteroscopy, and they've been floundering around for 2 to 3 years, you know, before they get that small bowel evaluation to try to identify what's going on. Usually sending them for, you know, radiology studies or nuclear medicine studies doesn't yield very much. And our best success would be to try to catch something on a capsule endoscopy and then follow up with enteroscopy. But it's important to recognize that sometimes endoscopic therapy, or not sometimes, many times, we do an endoscopic evaluation, and we just don't find what we're looking for. And the patients are still coming back into the hospital, and they're getting transfusions after transfusions. The medical service calls the GI service. We say we have nothing to offer. And then patients start to get put on different types of medical therapy, which up until the last couple of years has not really been well studied. And the two main things that we hear about are putting people on octreotide, which trying to get them covered on the outside with subcutaneous octreotide injection is really difficult. And then there's been some talk about thalidomide. You know, could thalidomide be something that is helpful? So there's a recent study in the New England Journal that you may have seen last year, and it looked at treating angiodysplasia, and they looked at patients that had bleeding more than 4 times in a calendar year. And they put them into 3 groups: the placebo, the 50 milligram group, and the 100 milligram group. The thought process around thalidomide is that it's an anti-angiogenic medication that impacts the vascular endothelial growth factor. And they wanted to see how these patients would do over the next several months, and was there a reduction in bleeding? And what they saw was the placebo group, you know, did the worst. And they had better success with 50 milligrams of thalidomide. There was a reduction, And there is even a greater reduction with 100 milligrams of thalidomide. And this is not something that we use regularly, but if you're stuck and you have a patient that is transfusion dependent, this is a medication, now that we have some updated literature, that you could consider to use in your patients. Same goes with somatostatin analogs. Again, these studies looked at the number of red cell transfusions someone would need to have. And again, you're seeing a decrease when you put these patients on something like octreotide. So these are important medications to consider versus just continuing to give blood transfusions, IV iron infusions, discharging them only for them to bounce back. Keep these in your mind because it can make a big difference for patients. And again, it's nice to see that we have some new data supporting them. So we're going to finish up with lower GI bleeding, another common thing that we see, over 100,000 admissions annually. And that patient is going to present with hematochezia or bright red blood per rectum. And your first thought is that it's the colon is the source of this bleeding. And you're probably right, because common things are common, but you always have to keep in the back of your mind, could it be from an upper GI bleed source? And when you think about diverticular bleeding, how many patients really come in unstable? Oftentimes they don't, they just report some bouts of rectal bleeding. They're just scared because of the degree of blood, but they're not telling you syncope or feeling really dizzy, and they're not really hypotensive. But diverticular bleeding is probably the most common in the group. But again, we have a laundry list of things that it could be. Diverticulosis being number one. Sure, someone could be bleeding from a polyp. You always have to consider an infectious etiology or a neoplasm. You should think about ischemic colitis in the right clinical setting where they're having pain and having bright red blood per rectum. A lot of times this could be sorted out with imaging. And if imaging doesn't answer the question, then you're going to move on to endoscopic evaluation. Just like I haven't seen upper GI bleeding scores in notes of the inpatient service, I haven't really seen the Oakland score either mentioned in many clinical notes. But this is, again, a risk stratification score that we would use for lower GI bleeding. And it looks at age, gender, previous admission, your heart rate, systolic blood pressure, and your hemoglobin level. And if you have a score of less than 8, you could be safely discharged. If it's higher than that, you should certainly consider admission. I think that this, again, is not used regularly, but it's good for clinical studies. So there are some key takeaways when we think about lower GI bleeding. It's important to assess the severity of the bleeding. So look at the whole patient, try to think of etiology and possible location. If they're hemodynamically unstable, you definitely want to fluid resuscitate them. Even if someone's having hematochezia and you're highly convinced that it's a lower GI bleed, you have to think of upper GI bleeding. Probably one of the things that we always go back and forth of, when is it safe to do an endoscopic intervention, something like a colonoscopy? What should the INR be? And that INR could be 2.5 or less, and you could safely do a procedure, and you could do endoscopic therapy and be successful, where you're not going to not be successful if the INR is 2.5 or less. So the patient doesn't have to be perfect. You look at the platelet count, ideally above 50,000, but 20,000 or less is where you're going to spontaneously bleed. So if your patients are above 20,000, again, you should be okay. You could continue aspirin, really do a good job of inspecting the lining of the colon, have good withdrawal technique. Important in these situations to go into the terminal ileum, because if there was blood in the terminal ileum, even though sometimes blood could reflux up into the terminal ileum, if you get a nice depth of insertion into the terminal ileum during colonoscopy, then you could say, well, it's not coming from the colon. Maybe it's coming from the small bowel, or maybe it's coming from the stomach or duodenum. Split dose bowel prep is important, and try to do colonoscopy within 24 hours. Offer endoscopic therapy. If someone rebleeds and the only thing you find during colonoscopy is diverticular disease and they're stable, you don't have to rush them back for colonoscopy. You don't have to send them to interventional radiology. You could just monitor these patients and they will be able to get discharged safely. When we think about radiology imaging, the takeaway from this, it's all about the timing, because you need the bleeding rate to be at a certain level for these tests to be accurate. So if you send someone for radiology imaging and it's negative, it doesn't mean they didn't bleed. It's just that the bleeding probably is slowed down to the point of stopping, or they're just oozing. And here you could see that if angiographies are performed within 90 minutes or less, you're more likely to find extravasation and IR intervention versus if it takes hours for them to get to interventional radiology. So what's the role of colonoscopy and radiology in someone with acute hematochezia? If you're low risk, you could do the next available colonoscopy. If you're high risk, you're going to consider interventional radiology. Oftentimes these things happen overnight. So you'll find that you contact the GI service, they'll recommend to the emergency room or the internal medicine team. If the person is really actively bleeding, send them to IR. That's probably their best chance versus doing a rapid colonoscopy prep. So when we have severe hematochezia, again, it's all about resuscitation, making sure to give a blood transfusion when appropriate. If it's ongoing significant bleeding, they're going to go to IR. If there's extravasation, you will treat accordingly. If there's no extravasation, which happens, you're going to move them down the colonoscopy pathway, looking to see if you could find the actively bleeding diverticulum, if there's an AVM or some other findings. What are the treatment options that we have when we do colonoscopy? When you're thinking of diverticular bleeding, band ligation, what we would use for varices, if you could identify that diverticulum and you could put a band on it, you're going to have a very good success of preventing rebleeding. It's only 8%. If we put clips, 19%. If we just do a heat coagulation, it's about 23%. We talked about some of the new advances in the upper endoscopy part of this talk of using over-the-scope clips when appropriate, using the Doppler probe. Those are things to consider, even using the hemostatic powder. If you come to a segment of the colon and you see active bleeding where you clear it, you suction, you irrigate, and then the bleeding starts to pool up again, the blood, that's a good area to consider doing that if you don't really have a good sense of the target. Post-polypectomy bleeding, we tend to just manage with clips. And if we see AVMs, angiectasias in the colon, our mainstay therapy anywhere in the digestive tract is argon plasma coagulation, which is quite effective. Another thing that often comes up, how do we manage anticoagulation in these patients for lower GI bleeding? Again, we could have hemostasis when the INR is less than 2.5. You could consider some vitamin K agonists. For the DOACs, you should just stop the medication. That's usually enough for you to move on to a procedure, but sometimes you could use some of these reversal agents depending on the medication these patients are. We tend to just stop the medication and then set them up for colonoscopy, which often is not the same day, but it's within 24 hours the next day. And if there's an ability to do hemostasis, we're successful with minimal rebleeding. This is just a strategy when you have a life-threatening severe lower GI bleed. What are the reversal agents that are available when you're on warfarin, dabigatran, apixaban? These are the things that you have to know to use. You should know that PCC is preferred over FFP when you're trying to rapidly correct someone's INR. Post-GI bleed for coming from the colon, what should we do? We should try to avoid NSAIDs not to aggravate diverticular bleeding. If you're on aspirin just for primary prevention, you could probably hold that. If you're on it because you have cardiovascular disease, you should not stop it. We don't stop aspirin for routine endoscopic procedures anymore. If someone needs to be on anticoagulation, this could safely be resumed after a lower GI bleed is behind them. So what are some of the final take-home points when we think about gastrointestinal bleeding from the top to the bottom? Know the guidelines. For those of you that are taking care of patients, getting them ready for endoscopy, the pre-procedure part is so important. Optimizing these patients, making sure they're getting the right hydration, doing blood transfusions when necessary. Communication with the endoscopy team is really important. Our goal as gastroenterologists is to try to make sure that these patients are examined within 24 hours. Capsule endoscopy on the inpatient service, which you're doing here, which is great, is really valuable to get timely enteroscopy and really understanding how to differentiate between a high-risk lower GI bleed versus a low-risk lower GI bleed. Risk stratification is important because you don't want to have patients have procedures they don't need, and you don't want to keep patients in hospital that could go home. Because bad things happen in the hospital, if we bring patients in and they don't need it. Thanks so much for your time. I'm happy to take any questions.
Thank you, Dr. Gross, for that very informative and illustrative grand rounds. We appreciate it, the review of all the possibilities. I'm wondering, how do you handle a patient that's admitted to the hospital and you're not really sure if it's upper or lower? So there's the schizophrenic gastroenterologist that says, well, we're going to prepare them for both. We're going to do one first, and if we don't find anything, we'll do the second. How do you feel about that sort of approach? Or do you really need to, commit yourself to one thing clinically and pursue that?
So it's a really good question. I think that if someone's having overt signs of bleeding, again, common things are common. So if you're having signs of melena or coffee ground emesis, the most likely source is an upper GI bleed, and just doing endoscopy is a very reasonable first step. It's not easy for patients. For those of you that have ever had a colonoscopy, you know what I'm talking about. When you're doing it at the confines of your home, right, and you're doing the laxative cleanse, it's not easy, but it's very doable. But it's not easy for patients to do it in the hospital. So I'm not a firm believer of we're just going to set every patient up for a double. We're going to do an endoscopy and we're going to follow what's obvious. And if that doesn't show anything, then it's very reasonable to, do the colonoscopy. That's for overt. If someone comes in with anemia that is really severe and they're not showing any overt signs of bleeding, so there's no bright red blood per rectum, there's no melena, and you're at that schizophrenic of like, what is it? In that patient, I have a lower threshold to say, you know what? Let's just give them sedation one time. I'm not really sure. Let's do an endoscopy and colonoscopy on them when it's a little bit more obscure.
Sure. Seth, this is Paul Martin here. Great talk. Can I ask you, I really liked your risk stratification of GI bleeds, but often we're presented with a fait accompli. The patient has already been admitted to hospital, and we lose the opportunity to maybe triage the patient, get a patient procedure done the next day or two. What's the strategy at NYU? Do you work closely with the emergency department to manage GI bleeds before they're admitted?
Yeah, so that's a really good question. So what do we do? What I shared with you today is the literature, right? The literature says, you try to do it within 24 hours. And if you're past 24 hours, you're behind. I work at a very aggressive, progressive health system. And we have algorithms and protocols that we're so intertwined with the emergency room and the surgeons and interventional radiology that if someone comes in with a very significant gastrointestinal bleed, one, interventional radiology and surgery are made aware. The gastroenterology team, we actually have a night float for the fellow. So our fellows are expected to come in to evaluate that patient. And if that patient needs endoscopy that night, they will have it, otherwise they will get resuscitated and they will have it first thing in the morning. The way our endoscopy unit runs, we have dedicated inpatient endoscopy time starting at 7:30. They have their own room. So we don't really miss the opportunity to capture these patients. And then we also have a lot of oversight. Just so happens our leadership are gastroenterologists. So if they see people coming in through the ER that have GI bleeding, for instance, I get a little message, what's happening with this patient? When are they getting their procedure? But that's a rarity.
Because I think it was the first where the GPS is really low. Here, they've already been admitted and it's too late for us to say.
Oh, I see. Yeah, so for that, I think that where we are, the emergency room is not admitting without talking to us. So we always get a phone call. Our fellow is always available and they communicate with us and we decide the triage plan together. So there are circumstances where the patient is evaluated in the emergency room and they go home. So no one sneaks by us. We communicate with them. Thank you for clarifying.
Dr. Mandel.
Yeah, so I think it depends on where the patients come from. You know, I see patients on oral iron or IV iron. They're usually already on IV iron when they meet me to try to do a small bowel evaluation. I think that it's becoming more and more popular. You know, as long as the patients tolerate that, it gives them, and they're not having a reaction to the infusion, they like it because they get a much better boost than they would with oral iron. Because with oral iron, you know, one, you have to tell them that's going to take a few weeks before they start to feel better and we start to see a rise in their counts. And then you also have to battle the issues of making sure they're on some sort of stool softener so they don't complain of constipation. But I am starting to see patients with chronic anemia being more on IV iron than oral iron. I'm seeing a shift. I don't know if you guys are seeing this in Florida, but I'm definitely seeing a shift.
Dr. Gross, thank you very much for that grand rounds. Thank you, Dr. Barkin, for being the named person for this lecture. And remind everyone who's on the Zoom to check the chat for the link for the CME and MOC credits. And those of you that are here, you can check the sign outside. Thank you very much again. Have a great day. See you next week.